Welcome, everyone. I'm Dick Deming, Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is lung cancer, and we could have no better expert than Dr. Neil Horning, Director of the Lung Cancer Program at Mercy Cancer Center, a pulmonary doctor and critical care specialist. Welcome, Neil.
Great. Thank you, Dick. I really appreciate the opportunity of talking with everyone.
Well, thanks for being here. Before we dive into our topic, let's get to know you a little bit.
Sure.
So refresh my memory. Where'd you grow up? Where'd you go to high school?
I went to Bristol, Tennessee High School,
Tennessee.
Yeah, I know. In East Tennessee, town of about 30,000 people.
Okay.
You know, I think our claim to fame is that half the town is in Virginia, half the town is in Tennessee.
Really? And which house did you live in?
On the Tennessee side.
Okay.
A good half. You know, and I think just recently, a couple of weeks ago, had the big baseball game at the racetrack there, the Speedway Classic with all the rain. But yeah, so they have a NASCAR track there.
Okay.
We have a NASCAR track there. But no, so
how many in your high school class?
Oh, probably a few hundred. It's definitely not a big city, but.
And what was your personal claim to fame in high school?
Oh. Personal claim to fame?
Yes.
That's a really good question. Well, I was in the band, and
what instrument?
I played clarinet.
Okay.
And did finish first in my class.
There
so I guess that maybe that's my claim to fame.
Yes.
I don't know. You know, I was not. I guess I wasn't voted, you know, the biggest smart aleck. So I guess there's that. I don't know.
So valedictorian.
Yeah.
Probably not homecoming king.
No.
Okay.
that always was. Yeah.
Well, usually there aren't very many valedictorians that end up being homecoming king.
No, there was the football players.
Okay.
You know, they were. I don't know. Back then, there were a lot of cliques, especially there. So there was like the people who were over here in the band, and the people who were in sports, and you know, other people. So I was sort of in the band, and you know, and that sort of clique. So we had a great time, though. I loved high school. It was
like,
great.
Can you still play a Benny Goodman tune?
I'd have to find my clarinet. I could give it a try.
And then when you graduated from high school, what'd you do next?
Went to the University of Tennessee in Knoxville, and majored in microbiology there, and then went to Washington University in St. Louis for med school.
Did you know entering college that you were on a path to become a doctor?
Yeah, well, you know, my father told me that I was going to be a doctor, I think when I was in third grade or so. So
was your father a doctor?
No, he was a pharmacist. He worked there was a pharmaceutical company in Bristol. Originally, it was S.E. Massengill, which became then Beecham, which was a pharmaceutical company in London, sort of bought them. So there was Beecham Massengill, then became SmithKline Beecham, then became eventually GlaxoSmithKline.
Okay.
So they sort of got enveloped
in
there.
But the town was Bristol, but it wasn't Bristol Myers.
No.
Script.
Yeah,
no,
different Bristol.
Just a Bristol.
But our claim, you know, they developed antibiotics. My dad was the head of regulatory affairs. So he would submit new drug applications. So he submitted the new drug applications for amoxicillin, Augmentin, Tygan, which is kind of come and gone. But every time I write another prescription for Augmentin, it's like, well, there's Dad. He did that.
And your microbiology was your major.
Yeah.
That was one of my majors as well. So then from Tennessee to WashU?
Yeah, in St.
school?
Louis. Right. Mm-hmm. So I spent 10 years in St. Louis.
So you not only did medical school, but then did your internal medicine residency,
right, and then pulmonary
and critical care.
Exactly.
And does is around the country, is pulmonary and critical care always together? Like,
most of the time, but not always. Some people do just pulmonary. Some people do pulmonary sleep. Some people do just critical care, and then there are those intensivists, those critical care docs there's other pathways like anesthesia critical care, neurology critical care. So it's kind of a mixed bag. Okay. And Dr. Gervich, who started our group back, you know, in the 80s, he was infectious disease critical care. So he was unique.
Right. And so then, so many years in St. Louis. How long have you been at Mercy Des Moines?
About 27 years, a long time.
Yeah. And it's such an important service, obviously, pulmonary, but critical care. And what change, we've seen in our career. It used to be that, you know, patients in critical care could have any one of a number of different doctors managing.
Right.
And, maybe 10 years ago, Mercy followed a path at other major medical centers and said, no, if you're in critical care, you're going to have a critical care doctor managing your care.
Yeah, exactly. I think as patients have become more complex, their diseases have become more complex, and the interventions that we have to offer have become more complex. It has become more and more specialized. And when I started, there were family medicine doctors and internal medicine doctors taking care of patients in the critical care unit, and now it's just that it's just not possible to be like a generalist like that who's seeing people in the office, in the hospital, in the critical care unit. There's a lot to do there.
Another thing that I've noticed, just as I follow my patients, and if they're in the hospital, I stop more to make a social visit than anything, that realizing that intubating a patient and in critical care, I mean, back when I was in training, like that was like the end of the road. And now there are many patients who might have pneumonia or some, low hypoxia, and you just kind of intubate them to keep them from getting worse and keep them oxygenated so that they get better faster.
Right. Yeah, exactly. And I think our treatments for underlying conditions like pneumonia or conditions like what we call ARDS, like this sort of terrible kind of acute lung disease where there's a lot of scarring and inflammation in the lungs, where people can't get enough oxygen out to the rest of their body. They need to be intubated on breathing machines. What we can do with ventilators now, what we can do with medications, and some of the other kinds of life support devices, life support machines that have come into existence in the last 10 years are really miraculous sometimes, a lot of times. So there's this thing called ECMO, which is extracorporeal membrane oxygenation. It's basically like a heart-lung machine that ordinarily is used in the OR, but now we can use in the critical care unit to keep people who are severely ill with bad lung problems, with shock, with bad heart problems, can keep them alive to buy time for their lungs to recover, for their heart to recover. Especially, we used it a lot, especially during COVID. That's where we saw a lot of people with really bad lung problems, and we're able to sustain them to keep them alive for them to be able to recover. And even now there's something called ECPR, which is, when their heart stops, when they have a cardiac arrest, we do CPR. And up until recently, you give medications, give electric shocks, and kind of sometimes their heart are able to recover, sometimes not. But for a certain subset of patients who are having that kind of cardiac arrest, who are really kind of clinically dead, we can put them on ECMO quickly and keep them going. And the idea is, if there's something fixable, especially with their heart, if there's some sort of coronary artery blockage or some sort of heart arrhythmia that can be fixed, we can keep them alive on the machine, on the ECMO machine and the ventilator, all those things. Give the heart doctors time to get their heart better and get them back alive again. And for those people, it's their survival rate is not 100%. That's for sure. It's more like 20%, but the survival rate otherwise without that would be 0%.
Yeah.
So those are people who are otherwise going to die that are now and we've had people walk out of the hospital. I think Dr. Pelayev, one of our doctors, saw one person who was incredibly sick, put up on ECMO, and just saw them the other day, just like yesterday, in the clinic. So it can be a miracle, and it's not a panacea. And but for those people, otherwise they would die otherwise. So for that select people who there's something potentially reversible, it can be a real miracle.
Yeah. So let's shift over to our topic for tonight, and that is lung cancer. And the reason we're talking about it is lung cancer is the number one cause of cancer death in the United States. And in the last 10, 15 years, we know more about how to screen for lung cancer. People know that, we've had mammograms for a long time. And if you want to improve the chances of curing breast cancer, you find the breast cancer at an early stage before it's symptomatic, and you have a much better chance of curing breast cancer. Same thing with lung cancer.
Absolutely.
So talk to us about how do we screen for lung cancer, and who do we screen for lung cancer?
So, for decades, many attempts were made to try to find the best way to try to screen for lung cancer. We tried, and we meaning scientists, tried looking at x-rays, using sputum tests, all these kinds of things. But then in 2011, the National Cancer Institute put together this national lung screening trial. And what they did were take patients who were deemed high risk for lung cancer and took half of those patients, randomized half to get a low dose chest CT scan versus a chest x-ray, basically a 2-view chest x-ray once a year for 3 years. And what they found was just in that 3-year time, those patients who had the low dose chest CT scan, they had a 20% relative reduction in lung cancer mortality and a 6.7% relative reduction in all-cause mortality. And the all-cause mortality is there's, when you get a CAT scan of the lungs, even this low dose chest CT scan that I'll talk about in a second, you see more than just the lungs. You see the heart with coronary artery disease. You see aneurysms in the aorta, see liver issues, emphysema, other things that can be intervened upon. And when we talk about a low dose chest CT scan, a low dose chest CT scan has about half the radiation of a normal CAT scan. So we tell folks it's a little bit more than radiation than a chest x-ray and less radiation than a regular chest CT scan. And what I tell people, it's the easiest screening test of them all, basically.
And it's also done without intravenous contrast.
Right, exactly.
It takes about 2 minutes.
Right, or less. There's no IV needed. Keep your clothes on. And some, we kind of jokingly, although not jokingly, tell them that it takes less time to actually have the test done than to check in or park your car or whatever. It's a really fast test. And so currently the enrollment criteria, those people who are considered high risk for lung cancer to have lung cancer screening are age 50 to 77, have to have a 20-pack year history of smoking. I'll talk about that in a second. And have had to smoke within the last 15 years. Current smoker or smoked within the last 15 years. And we talk about pack years. If you smoke 1 pack a day for 1 year, that's 1 pack year. 1 pack a day for 10 years, it's a 10-pack year history of smoking. It's just a way of kind of quantifying how much cigarette smoking somebody's done. If somebody smoked half a pack of cigarettes a day for 10 years, it's 5-pack year history. Anyway, so it's a way of standardizing that.
And just as an analogy, so in the world of breast cancer, every woman is considered at risk for breast cancer. So all women, we recommend mammograms. But this lung cancer screening, we only recommend this screening for individuals at high risk, defined by being a smoker and having a certain quantity of smoking.
Exactly. And, what has been found, or what was found in that initial study, has been borne out over the last 10, 15, 20 years of studies looking at screening, because, what we found is we find cancers early, which is sort of the whole point of any kind of screening. That 20% relative reduction in mortality is carried through. And the whole concept is just like with almost any other cancer, if you find lung cancer early, the prognosis is much better. An earliest stage lung cancer, the 5-year survival rate is like 90% or more. If lung cancers or other kinds of cancers, particularly lung cancer, is caught late, if it's spread to other parts of the body, the 5-year survival rate is sometimes less than 10%. So the whole point is to try and catch lung cancers early when they're potentially curable.
Right. And so again, screening doesn't prevent cancers, but it finds it early. I would say that a good lung cancer screening program also gives the opportunity to potentially intervene with some smoking cessation programming.
Exactly.
So it's really kind of immoral to just say, okay, everybody who's smoking, come on in, we'll screen you for lung cancer screening without intervening and saying, if you would like to, can we help you stop smoking?
Right.
Now
No,
that's actually preventing lung cancer.
right. Oh, absolutely. Absolutely. And our treatments to help us people stop smoking have improved also. And when the lung cancer screening was first sort of approved by CMS, approved by Medicare, that was a requirement actually to have a smoking cessation program. So here in Iowa, we've got Quitline Iowa. Within the Mercy system, we have our own MercyOne smoking cessation program. It's one of our nurse practitioners at our office, Ashley Tobin. She does a great job and can see people in person, see people over telemedicine, and follows them over time and has a really great success rate in helping people stop smoking. Especially, 'cause, I mean, in my office, and I'm sure in all my partner's office, everybody's office, there are patients who don't want to stop smoking no matter what. But there are a really high percentage of people who want to stop but just can't. It's the hardest habit to break.
It's a hard thing. My mom died of lung cancer. She did not stop smoking when she was diagnosed, but my dad did stop smoking when mom was diagnosed. So everyone's a little different on that. And we kind of meet people where they are and offer them the services, but don't judge if they decide that they aren't going to stop smoking, and still provide them the cancer screening. Absolutely. So the whole purpose, just to restate what you've already told us, the reason to do lung cancer screening is not to prevent lung cancer, but to find it at an early stage when it is curable. So let's take the theoretical case of a 60-year-old gentleman who smoked for 30-pack years and quit 10 years ago, but decided he wanted to comply with his primary care doctor's recommendation of getting screened. He comes and gets a screening low-dose CAT scan of his chest, and the radiologist says, we see a 1 centimeter nodule in your right upper lobe. Well, what happens next? How does he find out about the results of the CAT scan, and what's the next steps?
Right. So Casey Strovers is our lung cancer screening navigator coordinator. So she will notify, the program notifies the person who's had the CAT scan and whoever ordered it. If it's from the primary care doctor, if it's from a specialist, either cardiologists are ordering them, we're ordering them, but whoever ordered it gets notified also. And most of the time they are given the opportunity to see one of us pulmonologists to try and get an answer as to what this is. Here in Iowa, there are a lot of lung nodules. And so not every lung nodule turns out to be a cancer. We see a lot of this fungus called histoplasma. So, we try and tell people that not every nodule is going to be a cancer, but certainly, something of that size is going to be concerning, suspicious. So they would see one of us usually in the office, and we talk with them about, what their history, the risk factors, all those sorts of things. They've had a lung cancer screening CT scan, so they're already at risk for lung cancer. So most of the time, if patients, if the person who has the nodule wants an answer, and not everybody does, but if they want an answer, then there are different ways of biopsying that nodule.
And most people who've committed to getting a lung cancer screening
exactly.
are committed to finding out. So I know we have a relatively new technology within the last 10 years of being able to have a high success rate in biopsying. So maybe talk about this new form of navigational bronchoscopy. What is that, and how can that help determine what this nodule is?
Exactly. It's really been a game changer. What a bronchoscope is, for everybody, I know you know, but what a bronchoscope is a flexible fiber optic instrument that, just like a colonoscope or an endoscope, we use it to look in different parts of the body. The bronchoscope, it's about as big around as a pen, or kind of a big pencil, basically. It's not huge, but it's got a light and a camera on one end, eyepiece on the other, and we can use that to look inside the airways. And that's been around since, probably at least the 60s. But what's happened over the last 5 years or so, the ability to use that instrument to get biopsies has improved significantly. When I was in training, it was like using a fluoroscope and some forceps, because there's a side channel in the bronchoscope where you can run, put these little instruments down into the airways and get biopsies and get sample material that way. With this ion navigational robotic assisted bronchoscope, the way this works is that we can take the CAT scan that has been done, the lung cancer screening CT scan or whatever CAT scan has been done, as long as it's relatively recent, and use a computer program to basically make a map of the airways, make a map of the bronchial tubes.
And it's kind of like going on a street map and you come to forks in the road. And
Yep.
so every time you come to a fork in the road, do you go right or left?
Yeah, exactly.
So it helps you navigate your path through all the bronchioles to get to the nodule.
So with that roadmap, then whoever's doing the procedure, basically maps out where the nodule is and the best, airway to get there.
A right, a left, a
yeah,
right, a
exactly.
Right.
And then during the procedure, it's done under anesthesia, so people are asleep for this. Then go in with the bronchoscope, and the robotic assisted part is, through the side channel of the bronchoscope, this little these biopsy instruments, we can put those through, then use the robot assisted to follow the map that you've developed and go out and go directly into that nodule. Then, the other sort of even newer technique is now there's a special kind of fluoroscopy in the room where they can get almost CAT scan quality images to make sure they're directly in that nodule, to make sure that what they're biopsying is that spot. The other advantage, one of the other advantages of the ion bronchoscope, is we can biopsy more than one nodule at a time. That's more difficult if we're doing like the older technique of a CT guided needle biopsy coming from the out. What I tell people, you can come from the outside in, come from the inside out. The inside out is with the bronchoscope. So we can biopsy more than one nodule at a time, and also be able to sample lymph nodes with a different kind of bronchoscope called EBUS, endobronchial ultrasound, that's got an ultrasound probe on the end of it, and sample lymph nodes in the middle part of the chest. When I was thinking about this, back when I very first started, in order to sample those lymph nodes to stage a lung cancer, you'd have to call the thoracic surgeon and do a mediastinoscopy, and it was a big incision. It was a big surgical procedure. Nowadays, it's one of the more simple things that we can do with the bronchoscope.
And so you made a point of describing two different ways of doing a biopsy. So from the inside, going through the bronchoscopes, and then passing a needle to the tumor from the inside. The other way of doing it is to have an interventional radiologist rather than a pulmonologist. So the patient's in radiology on a CAT scan table, and the radiologist pokes a needle through the skin, through the muscles, through the lung, into the nodule,
right, exactly,
and pulls some cells out.
Right.
One of the problems of that technique is there's at least a 10 to 20% chance of getting a punctured lung. I mean, you are poking a needle through the lung, and so that's called a pneumothorax.
Right.
The way of doing it with the bronchoscope has a significantly lower risk of developing a pneumothorax.
Right.
Pneumothorax usually is resolved, but may require a chest tube. Right. Occasionally, someone could die from a pneumothorax, but
it's rare.
But in the lung cancer screening program, they did have a few deaths.
Exactly.
So anyway, two of the advantages of the robotic assisted bronchoscopy: less likely to get a pneumothorax, and you have a greater ability of getting to the nodule, and you can do more than one nodule at a time.
Exactly. And potentially also stage, we can diagnose with looking at the nodules, stage it by potentially either looking at on the other side. I think Dr. Greco, one of our partners, is doing bilateral nodules, which we never do in the past with a CT guided needle biopsy, and also stage the lymph nodes every now. I mean, it's, in other places it's been done. We've done it a couple of times where you can diagnose, stage, and actually do the surgical removal all in one procedure
under one anesthesia.
Yeah. So we've done that at least twice.
So What we've talked about now is the screening, lung cancer, low dose CAT scan for screening, and then the workup if you find a nodule. Then what's the next step in the path? Let's say
Right.
this nodule is now positive for cancer.
Right. So we see them back in our office as soon as we can. Usually we can get them. The whole concept is to try and get this all done as fast as possible because it's stressful for people, the patients and their families not to know. So we try and get folks in a few days after. It takes about a couple of days to get the results back. We try and get them back within just a few days into our office, talk about the results. Now, once we have a diagnosis and then a stage, if we haven't already had a PET scan done or some other staging, we'll get the staging done and then set them up in the multidisciplinary lung cancer clinic.
And what does the term staging mean?
Right. That means to determine if the cancer is spread anywhere or not, how extensive it is. If it's one single spot in the lung, that's an early stage, usually stage 1. It depends upon the size of the nodule. If there is spread of the cancer to the lymph nodes or spread to the other lung or spread to the liver or spleen, those are pleural effusions. So it's just determining, and stage determines prognosis and treatment.
Yeah. So as you mentioned, we also have a somewhat novel approach at Mercy Cancer Center in that we have a multidisciplinary cancer clinic for lung cancer.
Right.
So where the patient comes to the clinic and in one appointment setting meets the lung doctor, the lung surgeon, the medical oncologist, and the radiation oncologist. They are in one room and they meet all 4 of those doctors in one appointment period.
Right. Exactly. And we develop that because we want to try and make things as convenient for patients and their families and to try and get things done as fast as we can too. The longer the delay to you start treatment, the higher the risk of the stage advancing. We want to avoid that for sure. But also, back in the good old days when I very first started, we'd see patients back in our office and talk about the different options for treatment. Well, you could have radiation, you could have a stereotactic radiosurgery, or you could have, thoracic surgery. So you'd have to set them up to see, or you have to set them up to see Dr.
So the
Verhofstadt.
old-fashioned way, just to juxtapose, is you would take the patient to your office scheduler. That scheduler would call a scheduler over in my office. Then a week later, they'd be seen in my office, and oh wait, you haven't seen the medical oncologist yet. So that scheduler would call the other doctors, and then another week would go by before. So to see all 4 doctors, it would often be 4 weeks to get that done, as you do this serially, one doc at a time, and a week before each. And next thing you know, 6 weeks have gone by since you did the biopsy and no treatments happened. So this multidisciplinary cancer clinic where the patient gets to see 4 doctors in one appointment can definitely knock weeks off the schedule.
And it's more convenient. It's more convenient for everybody, but especially people who are traveling from other places, like whether it's Bloomfield or Newton or Knoxville. It's not easy to travel to Des Moines one time, much less 4 times.
And then there's also the conversation that happens amongst the docs that are
exactly. So, in the old days, we'd have to try and find each other over the phone or whatever. Now we're all meeting up there at the same time. We can talk about what we think needs to be done. What else needs to be done? Oh, we need another biopsy, or we're concerned about this nodule, or is this person a surgical candidate or not? What are their lung function tests look like?
Good enough to lose part of one lung.
Yeah, exactly. And they can meet the lung cancer navigator, all in that same, Donna Van Berkom is our lung cancer navigator, does a great job. It's invaluable service from the cancer center, and she does a great job working with families. And the other thing is that the families, if a person can drive themselves, that's one thing, but oftentimes people either aren't able to or don't want to drive in Des Moines. So somebody needs to take off work to drive them. And so the old way, they have to take multiple days off of work. Now, all one time, and family members from out of state can either call in or Zoom in, because that's one of the nice things about the cancer center up there. They have a really nice telemedicine or telehealth sort of availability. So
Yeah.
it's worked out really well for folks.
So now let's talk about they've been seen in the multidisciplinary cancer clinic. We also have a multidisciplinary cancer conference
Right.
that we do. And what's the role of the cancer conference, and how does the decision get made on how to treat? And let's start with this stage 1 situation. So we're going to define that as a single tumor in one lobe of one lung with no evidence of involvement of lymph nodes or spread of cancer anywhere else. Those patients have multiple options available to them.
Exactly. So, so generally the options are either surgery to remove it, to, and we could talk about sort of their advances that they've had that happen in surgery, because that's pretty exciting too. But it's surgery or stereotactic radiosurgery, CyberKnife. And, that breaks down something that is one of the reasons why we have the multidisciplinary clinic and the multidisciplinary cancer conference. At the conference, it includes multiple specialties: pathology, radiology, pulmonary medicine, medical, radiation oncology, thoracic surgery, and all the support team, the research teams, also the folks from palliative care, hospital, all of those sort of support folks too. But about this person with the stage 1 cancer, generally it depends upon, when it comes to the decision for surgery, part of it is, are they medically able to tolerate surgery? Meaning, is their lung function good enough?
Is their heart good enough?
And exactly, are they medically able to tolerate it? And if they are, then what do they, what are their goals of care? What do they want? Sometimes people don't want surgery under any circumstances. Sometimes people have medical reasons why they can't have surgery. So that's where radiation oncology, takes the lead. Sometimes people say, we had a couple of folks yesterday in the clinic said, get this. My aunt was like this too. She had lung cancer. She said, get it out yesterday. Get this thing out of me right now. So she was like, she wanted surgery and didn't want to hear any other options. But so where the multidisciplinary clinic, the conference comes in, we can talk about, the pros and cons of these different options, what their medical issues are. Like one of the folks yesterday in cancer clinic had coronary artery disease. So they're going to need to see the surgeon before they can, be finally cleared for surgery. But at this cancer conference that happens every other week, we discuss cases like this to try and oftentimes, this is sort of a more of a clear-cut case. A lot of times things aren't so clear-cut when it comes to what are the best options for treatment, or what other things do we need to try to diagnose what these lesions are.
Mm-hmm. Yeah. And then, but typically speaking, a stage 1 lung cancer patient typically doesn't need chemotherapy. So it usually comes down to either surgery or radiation as the option. Once we get to stage 2 and 3, then we often do might involve chemotherapy and radiation together.
Exactly. And I think, and that's where the multidisciplinary part of this comes in. And also, the medical option, we talk about chemotherapy. Sometimes people in their head imagine the kind of the battle days of chemotherapy. And one of the many advances that have happened in lung cancer over the last decade are our understanding of tumor markers and how those tumor markers can help direct different kinds of immunotherapy, different kinds of medical therapy. The medical oncologists have a lot of options to offer people now.
Targeted therapy.
Exactly.
Yeah. So tell us a little bit more about markers, because it plays a huge role once you get to stage 2 and stage 3 and stage 4.
Right.
Cancer.
Exactly.
So what's a tumor marker?
Well, these are these markers, these cells that are on, or these
they're characteristics of the cancer cell.
Right, exactly. They're characteristics of these, when the pathologist gets the pathologic tissue, they can do these tests to look for these certain kinds of markers on the cell. They run these sort of tests and do these genetic tests. It's sort of, these are genetic abnormalities within the cancer cell itself to look for. There's, KRAS and PDL1 and all these different kinds. There's a whole battery. I think every few
EGFR
weeks.
and ALK
Exactly.
and ROS1, and there's
Right,
about
exactly.
30 different actionable markers on a
Right.
cancer cell for which we have invented treatment that is very specific for
Exactly.
cancer cells that have those particular abnormalities.
Exactly. And now the medical oncologist can choose what kind of medication is going to be best, have the best hope of improvement in the cancer from the treatments that they're giving. So no, it's really kind of it's actually a revolution, not kind of a revolution.
And as you mentioned, we do have an active research program. So I really think it's incumbent on those of us in cancer centers to make sure that we're continuing to evolve and improve. And one of that is to have clinical trials.
Yep.
Just in the last few years, we've now become standard of care that for stage 3 lung cancer, you get chemoradiation and immunotherapy.
Right.
And the only reason that became the standard of care is because we did a study where you did chemoradiation without immunotherapy for half the patients, and you did chemoradiation plus immunotherapy for half the patients, and lo and behold, you had an increased survival rate for those who got the immunotherapy. So that now becomes the standard of care.
Exactly. So I mean, it's really remarkable what's happened over the last several years with how we can, prevent with smoking cessation, find it or diagnose it, or find it with lung cancer screening, diagnose it with these new diagnostic materials, and now treat it. And the surgical treatments have also advanced significantly too.
You know what? Let's go back to our stage 1 patient, because we already said that the treatment options usually comes down to either surgery or radiation. Both the surgical techniques and the radiation techniques have evolved significantly for stage 1 lung cancer. So why don't you tell us first about minimally invasive lung cancer? So kind of what the classic thoracotomy and lobectomy was, and how some patients might be able to undergo surgical removal of their lung cancer with much less invasive procedure.
Right, exactly. In the good old days, a thoracotomy was a big incision along the back, almost like right
halfway around.
Yeah, exactly. It was a big incision. They would have to use a rib spreader to spread the ribs apart and then remove that section of the lung, that lobe of the lung. And the outcomes from the cancer standpoint were good, but the problem is there was a lot of morbidity, meaning that, especially people would have pain that would last pain that would last for a while, and this unusual numbness in the front part of their chest, and that this pain would last sometimes for weeks and weeks, sometimes longer. The numbness would last
for the rest of their life.
Yeah, exactly. Exactly. So it would require more pain medication. Sometimes you'd have to go to the pain center to get the nerve blocks, to get the intercostal nerves numbed up and blocked. So, and be in the hospital sometimes, more than a week. Nowadays, just like you used to, you can still take, nowadays we can take gallbladders out with, with just tubes, basically, these little tubes go in, and the robotic little hands can help do these procedures. Can do that now with lung tissue as well. So these minimally invasive lobectomies or wedge resections, where they cut out just the section of lung tissue, they can go in with just a few tubes that aren't very big. They don't have to spread the ribs, and can have just as good outcomes from the cancer standpoint, but a lot less morbidity, a lot less pain and suffering. Don't have to be in the hospital as long, and don't have this sort of unusual numbness and this sort of nerve pain that people would have after the big thoracotomies.
Yep. So that's the minimally invasive surgery. And in the world of radiation, we've also gone to being very much more precise. And so instead of in the really good old days of 50 years ago, you treat from the front and the back, and everything in between got the same high dose, whether it was the pectoralis muscle, the normal lung in front and behind the tumor, or the tumor. And now with robotic stereotactic radiation, you might come in from 100 different directions. Each of the beams gives 1% of the dose. They all focus on a single point that gets 100% of the dose, but the surrounding tissue might get only 1%. So just as in minimally invasive surgery reduces the side effects of the surgery, the robotic radiation reduces the side effects of the radiation.
Yeah, we see a lot less. I can't remember the last time I've seen someone with radiation pneumonitis, or the people who would have a lot of esophageal problems, trouble swallowing, any of those things from a lung cancer radiation. I don't think it's been a long time since I've seen that.
Yeah. So advances in those treatments. Let's talk some more now about stage 4 lung cancer. What does that mean, and what why do we want to find cancer before it becomes stage 4?
Well, stage 4 just means it's metastasized somewhere else in the body, whether it's to the other lung or liver, brain, wherever. And unfortunately, the mortality from the 5-year survival rate's unfortunately pretty low, like 10%. Survival rate for early stage cancer, 90%. 5-year survival rate for metastatic lung cancer, like 10% or less. And the treatments there, surgery is not an option for those folks. Then sometimes it's like radiation, palliative radiation, and things that the treatments that the medical oncologists can offer, whether it's chemotherapy, immunotherapy, those sorts of things. We can do things for people who have malignant fluid collections around the lung, malignant pleural effusions. One advancement that's happened in the last probably 15 years are these Plerex chest tubes that can be, they're very small drainage tubes that can sit in the fluid around the lung, and people,
and the patient can go home with
right,
those,
exactly, and they can do the drainage
on them.
Basically it's just a little suction, like a little vacuum container that they hook up to this every few days and drain the fluid out, because really we're just trying to help people feel less short of breath from that fluid. And back in the old days, they would have to come into our office every week and get that drained out. But with the Plerex catheter, they can deal with that at home. So
I would say one of the biggest treatment advances, and this is just elaborating on what you already talked about, the genomic testing, the testing of the cancer cells. There are some individuals who have a type of lung cancer with where the cancer has a particular mutation, and the two that we have the best results with are ones where the lung cancer cell has ALK mutation or EGFR, and there are oral pills that are targeted therapies that actually can keep the lung cancer under control for years. So stage 4 lung cancer, in my experience, the individuals who have that type of lung cancer with those mutations, in my experience, have been women who are non-smokers.
Right. Yep.
And the typical types of lung cancers that smokers get tend not to have those mutations, although they may. But for some reason, women, non-smokers who get lung cancers have a much higher likelihood that they might have this genomic mutation of the cancer cell, not a gene that they inherited from mom and dad, but the cancer cell having this abnormal characteristic for which we have an oral pill that can keep it under control.
Exactly. Yeah, it's so much different than it used to be. It's really great. And we have, now options as far as palliative care, a lot more of a support system around patients than we used to. With Donna, our lung cancer navigator, and support systems through the cancer center. I think it's people aren't sometimes people felt kind of adrift, 10, 15, 20 years ago. Now I think there's a more of a support system around
by support and care. So we mentioned that cigarette smoking is the number one risk, but that individuals who don't smoke also can get lung cancer. So what are some of the other risks for developing lung cancer besides cigarette smoking?
Yeah, here in Iowa, radon. And, it's probably, here is a significant risk factor, particularly people who smoke and are exposed to radon, I think that's without question an additive or
And
multiplicative.
how are people exposed to radon?
Right, exactly. So radon, it's just an odorless gas, an odorless, tasteless gas that just comes from the ground.
It's not a pollutant. It's
No,
part of
it's
the
just
way the
part
earth
of the
was made.
geology. And unfortunately, Iowa has one of the highest levels, not the number one level of radon. However, it's the households. Iowa has the highest percentage of households in the country that have the higher than safe level of radon. Like 71% of homes in Iowa have a higher than safe level of radon. So realistically, people should consider getting testing and getting mitigation systems, those sorts of things, particularly if you're spending a lot of time in the basement and smoking.
Yeah. So we mentioned smoking is number one. Obviously, there's primary smoking where the individual is the smoker. There's secondary smoking, which is you're in the room, whether it's your own home or a casino where others are smoking, but you're inhaling the smoke. And then there's third-hand smoke, which is you're in the room where smokers have been. There's not smoke in the air, but there might be smoke in the cushions, or there might be or let's say a worker, a preschool teacher doesn't smoke at the school, but there might be smoke in the clothing. That's third hand smoke. So you can have first, second, or third hand smoke. We're also in Iowa wondering about what types of cancers might be caused by all of the chemicals in the air. I mean, modern living is chemicals, but when you live in a state where 80% of the land is row crops that have more tons of chemicals put on them than any other state, we know that the increased risk of cancer is attributed in part to all of the chemicals we absorb in the water and the air. We wonder whether lung cancer might be also affected by those chemicals.
Yeah, the lung cancer rate in Iowa is higher than in some other states. We're not number one, but we're higher than sort of the average for new cases.
And we have a
cancer.
lower than average smoking rate compared to the rest of the country.
Exactly. About 14% of Iowans are still smoking.
Huge advance over, when I was growing up in the 50s, 50%, more than 50% of men smoked. And that has decreased significantly because of public policy, education and public policy.
Yep, exactly.
What else about lung cancer should we discuss that we haven't touched on yet?
I think in general, there's been, as we sort of said, huge advances, whether it is in prevention, meaning stopping smoking, screening. And I think the other thing that we haven't really talked about are incidental lung nodules. These are people who have a CAT scan or some sort of other radiology test that's done for some reason other than just looking for lung cancer. Someone comes into the hospital, the emergency room with chest pain, and the ER doctor wants to rule out a blood clot in the lung, so they get a CAT scan. There may or may not be a blood clot there, but there may be like a 1 centimeter nodule there. And in the old days, that sometimes would fall through the cracks between communication between the ER doctor and the primary care doctor, and that would sit and grow and grow and grow and metastasize, be a big problem. So about 10 years or so ago, we developed an incidental lung nodule program where the radiologist would flag that report. That report would go to our navigator. The navigator would kind of make sure that gets, worked up. If it's significant, get them us, talk to the primary care doctor, get them into us, get them a biopsy and find those that way. And in actuality, the percentage the percentage and the numbers of cancers that we found through that incidental lung nodule program were actually higher than in the lung cancer screening program. Wow. Now, what we have now is, that was where the radiologists were flagging it. Then we moved to a system where we're using kind of an AI where the reports are being read automatically. And now we've moved into an even more advanced system. But basically trying to find these lung nodules early. The whole point of all this, whether it's lung cancer screening or the incidental pulmonary nodule program, is to catch lung cancers early before they metastasize, because the prognosis is so much better
Yeah.
if we can catch them early.
Yeah. And just to restate what you already told us, stage 1 might have a 90% cure rate, 90% 5-year survival. Stage 4, maybe a 10%. Huge difference.
Yeah,
Are
exactly.
you up for some questions?
Sure, absolutely.
Yeah.
Definitely.
So live studio audience members get the first questions of Dr. Horning. If you're watching us live streaming, you can put your question in the comments section of the software that you're using to watch us this evening. Gary, you're up first.
Yeah, right at the end, you kind of asked the question that I was thinking about, the path of, of other factors of
Other things that cause
it.
cancer.
Yeah, it's supposed that, you don't, you're not a smoker, but you just have, that there's that possible incident where you can. How do you determine whether or not you should at least take a scan to determine that? And, unless you have something that happened that some
Right.
incident, what things should we think about?
Right. Sure.
To do
So,
that.
I think the answer is, I'm sorry. The answer is with lung cancer screening, there's some pretty strict criteria to get into to have that lung cancer screening CT within that program. Age 50 to 77, all those things you talked about, 20-pack-year history, smoking that in the last 15 years. But there are people who have a high, have a family history that's really concerning, or there's something else that's gone on that makes them concerned, right? And the other sort of frustrating thing is that smoking is cigarette smoking, not cigars, not pipes. Those things are risk factors too, but CMS, insurance companies don't recognize that because the original study just looked at cigarette smoking. So I think the real answer is you need to talk with your provider, whether it's a physician, nurse practitioner, PA, talk with them about your concerns. People talk to me about that, not infrequently. And we can find ways to try to get testing done. Not necessarily through the lung cancer screening program, but other ways of doing that. If there are other symptoms that are going on, we can get a chest x-ray. If there's something on the chest x-ray, then we can get a CAT scan, those sorts of things. But I think the real answer is, talk with your healthcare provider about what your concerns may be and see what their thoughts are about how best to try and get, to allay those fears and get you tested.
Other questions?
I have another one.
Okay.
Last week we had this session on with a new type of instrument.
Mm-hmm. And we talked about histosonics, which is a focused ultrasound to kill cancer, to eliminate tumors in certain parts of the body.
Yeah, has there been any thought, through your discussions? Probably Dr. Deming, you know best about this, and Dr. Horning, the fact that being able to use this type of a instrument to be able to cure the cancer.
Good question. I think there is research going on to try to look at those types of instruments. I think nothing's been FDA approved or proven yet, but there are lots of studies going on looking at that to try and do something along those lines.
Yeah, especially with a localized tumor, you can kill a localized tumor with heat, radiofrequency ablation, with cold, cryotherapy, with focused ultrasound, with radiation. So in order for any of those devices to be used, there has to be clinical trials done demonstrating that they're safe and effective. And so there's research being done, but right now those tools aren't being employed for early stage lung cancer. But I suspect that each of those things I mentioned, there are companies that are looking at that for lung cancer as well as for tumors in other parts of the body.
Yep.
Question over here, Kevin.
Yes, is there any kind of surveillance or screening program for people who have worked in environments that might be asbestos or grain dust or a coal mine, something like that? Those could all lead to those factors in lung cancer.
Yep. Good question. I think asbestos, they have their own program looking for And a coal, you talked about coal mine too. There's the black lung program through the government. I don't think there's, I'm not sure, through screening for asbestosis or those sorts of things. I'm not positive if there is an official program either through like the pipe fitters union or those sorts of things, those types of people, or through the military. A lot of people got exposed to a lot of asbestos through the years, whether it's people on the railroads working on brake linings, whether it's pipe fitters. The people who I've seen who've had really bad mesothelioma have been pipe fitters and people who've worked on railroads. But I'm not aware of an official screening program that we do for those folks. I think through the VA, there may be screening for, potentially for the military. I know that there are screening programs for people who were exposed to like burn pits over in Iraq, looking for this particular kind of lung problem, this bronchiolitis that people got from burn pits. But right, exactly. But I think probably the thing to do for people who had those kinds of exposures, again, to kind of talk to their doctor, let them know what they feel like is going on, and to get them to a lung doctor, and we can start to work that stuff up. I get plenty of x-rays and CAT scans on people who've had all kinds of exposures.
Last question, Tim.
You touched upon this just a little bit. As a regular person going to the ER with a chest pain, and from the chest pain, you do the different types of screenings and diagnostics and determine that, well, you have cancer. Is there other types of things that a person can look for before screening to say, oh, I have a pain in my left chest or in my thorax or something like that? What other types of indicators as a regular person would they expect to?
Good question. What are the signs of lung cancer?
Yeah, I think, and the difficult thing is most of the time early stage lung cancer doesn't have any signs or symptoms. That's the bad part. Kind of like some other types of cancer, like ovarian cancer. You don't have a lot of necessarily signs or symptoms until things have progressed. So the things to be concerned about that may be indicators that someone has lung cancer would be, and it's pretty non-specific, unfortunately. It's not very specific, whether it's chest pain, especially pain when you take a deep breath, persistent coughing, especially coughing up blood, fever, night sweats, weight loss, those sorts of things. Again, that can be anything. That can be just plain old pneumonia. Honestly, it's more likely all that stuff I just said may more likely be just a bad pneumonia, not lung cancer. But those are sort of things that I think would lead someone to say, I need to talk to somebody, whether it's urgent care or ER or to your doctor, nurse practitioner, somebody. I mean, if you got fever, night sweats, weight loss, coughing up blood, that's the time to seek help.
So if somebody has symptoms, a doctor can order a CAT scan. You'll get a regular CAT scan.
Yeah.
It'll get approved. The type of CAT scan we're talking about is for screening who people have no symptoms, and you want to do the CAT scan. So if somebody has symptoms, insurance will pay for a CAT scan. But if somebody has no symptoms, we only can get the CAT scan if they meet the criteria for lung cancer screening, which is the criteria Dr. Horning mentioned. So it really comes down to getting it paid for, doing a CAT scan on people who have no symptoms.
Yeah.
And that's what screening is.
Right, exactly. And one of the criteria is for lung cancer screening, having no symptoms of lung cancer, actually.
And we have run out of time. So we'll have you back again. Dr.
Right.
Neil Horning, pulmonologist, critical care specialist at MercyOne. Thank you for being with us.
It was great.
This
It's my
evening.
pleasure. My pleasure. Thank you very much.
If anyone watching this knows someone that would benefit by watching it, this program will be available on demand, watching it anytime you want on the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. I hope you will join us again next week. Thanks, everyone.
Thank you. Thanks.